Hello. Thank you everyone for joining us for this Health, Racism, and Communication seminar. We're very excited. I'm Shopre Ramirez with the Center of Excellence in Maternal and Child Health. We are co-sponsoring this along with the Prevention Research Center, the Mary Amelia Center, and the following student organizations. The Society of Young Black Public Health Professionals, Tulane African Students Association, or TASA, Students United for Reproductive Freedom, or SURFTUF, and Salud for Latin American Community. So thank you to all of our co-sponsors, and thank you to all of you for coming. If you didn't already, please make sure you get an evaluation form. I'm also going to take this moment to encourage you to come to our third seminar next Tuesday, same time, same place. And to let you know that we are aware that many of you have class at 1, so we're going to do like a little pause right before that. So those of you who need to leave can. For those of you who are able to stay till 1:30, please do, and we can have some more Q&A. So I'm going to pass this over to Isabella.
Good afternoon, everyone. Hi. I'm here to introduce our wonderful speaker, Julie Fitch. Julie Fitch is the Testing and Capacity Supervisor at the Louisiana Department of Public Health and the Office of Public Health of STD and HIV programs. She has been there since 2006. Prior to her work in the STD and HIV field, Julie served as a community outreach coordinator at the Louisiana Coalition Against Domestic Violence. In 2017, she was selected as a culture of health leader, which is a national leadership program supported by the Robert Wood Johnson Foundation to support leaders from all sectors that have an influence on people's health, to create collaborative solutions that address health inequities and move their communities and organizations toward a culture of health. Julie is dedicated to the work of social justice and building meaningful relationships with communities through her work in HIV, STD, and hepatitis prevention. Please welcome our speaker, Julie Fitch.
Thank you. All right. Can everyone hear me okay? All right. Thanks for coming this afternoon. Thanks to Tulane for including me in the Health, Racism, and Communication series. I'm really honored to be a part of it, and y'all should come back next week to hear Troy speak because she's amazing. So again, I'm with the Louisiana Office of Public Health STD HIV program. I've been there about 11 and a half years, and the whole time I've been working in the prevention department. So I'm not going to like do an organizational chart of the program, but just to know that there are many different facets and programs within the STD HIV program. We are federally funded to track and prevent HIV, STIs, and viral hepatitis. One of the many departments is the services unit, and they are funded federally to ensure the provision of services for people living with HIV. So today, I have two things that I really want to get done in my short time with you all. The first, I'm assuming folks have some general ideas about what HIV and other STIs look like in Louisiana, but to just maybe do a quick overview and explain some of the HIV STD disparities, specifically related to race, gender, and sexual orientation. So we focus on these three types of disparities because we know based on the data that we have that communities of color, gay and bisexual men and same-gender loving men, as well as transgender individuals, do bear the burden of HIV and some STIs in our state. So it is incumbent upon us to understand not just what the disparities are, but how they are inequities. And then the bulk of my presentation today is going to share some stories and examples of how we are working toward health equity in the STD HIV program. So that's going to be the majority of what I'm talking about today. So just real quick, I wanted to make sure we're all on the same page with the distinction between a health disparity and a health inequity. So a disparity is simply a disproportionate difference in health between groups of people. But a disparity in and of itself doesn't explain how it came to be, the history and the patterns that set it up, or the context that keeps it in place. But when we talk about health inequities, it does take all of that into account. We're not going to have time today to fully explain all of the inequities related to HIV and STI. To do that would be to have a very deep conversation about the history of racism and heterosexism in the United States and in Louisiana specifically, and I just can't do that in an hour. But I just want to pull that out right up front, that it's really important to understand that context, and we'll return to that point over and over again. Equity, what we're going for, is a fair, just distribution of social resources and opportunities needed to achieve well-being. So this is also different than equality, right? So if myself and another person walk into a clinic and we are provided the same exact services in the same exact way, that's equal service provision, right? Not that that's a bad thing, but that's different than equity, because what I need to be a whole, healthy person might be different than what another person or another community needs to attain their ideal health and well-being. And this graphic is from CDC. I just pulled it out to marry the concepts and just to underline the point that reducing health disparities brings us closer to reaching health equity. So there is obviously a relationship there. Just wanted to tease out some of the differences. At the STD HIV program, we have a health equity action team. It's called HEAT. It's comprised of people from all different units, and our vision for equity in HEAT is that equity will be achieved when rates of HIV and STIs are no longer predictable by race, sexual orientation, and gender identity. So right now, and we'll see some data in a second to show that unfortunately right now it is very predictable in our state, and that's not just true for Louisiana, that's true across the nation, specifically in the American South. So these are our rankings. Some of you may have seen this already, but the CDC, which is the Centers for Disease Control, put out rankings based on case rates. So how many people per 100,000 have a particular condition, and it's a way that we can compare, a state the size of Texas with a state the size of Delaware. So in Louisiana, we rank, these are the 2015 and 16 rankings, we pretty much stay in the top 5 for all these conditions: primary and secondary syphilis, congenital syphilis, gonorrhea, chlamydia, AIDS, and HIV. If we went before 2015, the picture will look very similar. When the 2017 rankings come out this year, we hope to see some improvements, but it's probably going to be somewhere similar to what you see here. And then if the last slide was about case rates, this is about actual diagnoses in 2016 and 2017. So here you can see that we did make some improvement in primary and secondary syphilis and HIV from 2016 to 2017. However, we see increases from one year to the next in congenital syphilis, gonorrhea, and chlamydia. So now we are going to shift to disparities. This slide is focused on race and ethnicity. It shows trends in new diagnoses from 2007 to 2016. And if you look at 2016 in particular, you'll see that Hispanic or Latinx folks had an HIV diagnosis rate that was about 3 times that of white individuals, and that Black or African American Louisianians had a diagnosis rate that was 6 times that of white people. And to put this another way, new diagnoses in 2016, 73% of them were amongst African American people, but they only comprise about 1/3 of our state's population. So that is an extreme disparity. And here it is by gender. So 71% of new HIV diagnoses in 2016 were among men, 27% among women, and 2% that we know of are among transgender women. And so just right off the bat, I want to say that one thing that healthcare institutions can do to move toward equity is to accurately capture gender nonconforming and transgender individuals by asking a 2-part question, one about assigned sex at birth and a second question about current gender identity. Because that's the only way for us to really have a clear idea what's going on with our trans brothers and sisters. Otherwise, we're serving, we are, supporting the invisibility of whatever the real situation is, regardless of what health condition you're talking about as it pertains to gender nonconforming and trans folks. Okay, and this is a tree map, also from 2016, and it combines race, not gender, but sex at birth, and it adds transmission category. So the dark and light green boxes are Black and African American men and women. The dark and light blue boxes are white men and women. The dark and light gray boxes are Hispanic or Latinx men and women. But right now I want to focus on the largest dark green box, and it says Black male MSM. So MSM is a CDC transmission category that stands for men who have sex with men. And so Black, gay, and bisexual and same gender loving men comprised 42.7% of all new HIV diagnoses in 2016. So, this tree map is really important for our work in terms of equity, because it shows that we cannot focus on race to the exclusion of gender and sexual orientation, and we cannot focus on gender and sexual orientation to the exclusion of race. Because there is clearly something about the lived reality of being a Black, gay, or bisexual, same gender loving man in Louisiana that puts those folks in that community at greater risk and more vulnerable to HIV and other STIs. So intersectionality is really important in the work we do, and I don't know what all you do, but I'm venturing to guess that it's probably important for a lot of you as well. What else did I want to say about that? I did want to mention that all of these stats come from our annual report. I put 3 of them up front, and y'all can feel free to move them around the room. It's also available, our annual report, online at ldh.la.gov and louisianahealthhub.org. But here we see that that disparities, it's not just about diagnoses, disparities persist into care. So this is young gay and bisexual men living with HIV in 2016. Young we're defining as ages 18 to 24. And 69% of young Black, gay, and bisexual men who are in care attained viral suppression versus 87% of young white, gay, and bisexual men who were in care that they attained viral suppression. And viral suppression is just meaning that you have suppressed the amount of the virus such that it is undetectable in laboratory testing, right? So even when we isolate for age and sexual orientation, that a racial disparity still exists here. Right. And then finally, didn't want to leave out syphilis. So primary and secondary syphilis, this is by gender and race ethnicity last year in 2017. And really just wanted to make the point that our syphilis epidemic in Louisiana very much mirrors our HIV epidemic. So one of the things we've been doing is as we offer and support HIV screening and testing around the state, we're adding syphilis testing as much as we can, because we're thinking like the same places that would be good for HIV testing, given our data, are also good for syphilis and additional STI screening as well. So we're in a process right now of adding gonorrhea and chlamydia, extragenital gonorrhea and chlamydia testing in multiple and varied sites. So now I'd like to shift gears, and I'm going to ask you all to indulge me in an exercise. If you would just take like 3 or 4 minutes and speak with the person sitting next to you and just share what you do, and then share with your partner why you got into the field of study that you're in, or if you're out in the workforce, why you got into the type of work that you're doing. And again, just 3 or 4 minutes. All right, let's come back together. Thank you all for so enthusiastically participating. So can I get maybe a couple volunteers, someone who's willing to just like shout out a word or a phrase about what drove you or motivated you into your field of study or your work? Okay.
I was telling Jackie Scott here, I work for prison care, I'm a data analyst, HIV counselor, and I want to do everything you do.
Oh.
I also am a 2020 Albert Schweitzer Fellow. My specific project deals with HIV, it's a 3-part project, so I walk around or ride around in a mobile clinic all day and test people at barbershops, universities, even on the street for HIV. I also do research in Black, cisgender, and transgender women and their rates of HIV in New Orleans. And my interest in the project was born of being a Black woman and born and raised in Louisiana and having HIV is culturally rooted in our community.
Thank you for sharing all of that. Appreciate it. Anyone else?
Compassion. I am a case manager here in New Orleans. I house people who are chronically homeless with mental health and or substance abuse issues. So I saw this on Facebook. A good friend of mine, Dr. Eric Riggs, shared it as well. And I came today because I've found some free content and also to learn more why the disparity exists. Of course, the role does reporting goes for as a public position and for as a private position, and what is in place to decrease the numbers.
Thank you. So you saw a need for the work that you're doing now, and you had compassion for the folks who are, you said, are homeless and have other types of needs there.
Right. So
Yeah.
you know that it's so funny. I met this young lady. I'm sorry, not Kate. So Kate works for Crescent Care. Yes. So my client just got tested for HIV, and he was showing me paperwork through Crescent Care and gave me the information. They referred him to other programs, and so then I sat next to Kate, and that's
It's beautiful, isn't it? That's great. I love that. So yeah, so we are aware of these social issues, these problems facing our communities, and we want to do something about it. But how can we solve problems without understanding how they came to be, right? Like, what's the source of all of this? And so I'm going to move into sharing how our equity work at the STD HIV program is playing out internally in terms of how we're changing how we work with one another internally and our practices internally. And then I'll move into talking about how it's equity work is shifting our external relationships and practice, meaning those ways that we intersect with communities and with other organizations. And I'm hoping some of this might be helpful for you to take back. So back to that question of like, how can we address a problem if we don't really understand where it came from or the beginning of it? We started with training at the STD HIV program. Back in 2013, we started offering Undoing Racism workshops. They're facilitated by the People's Institute for Survival and Beyond. They are 2 full days in length, and they really focus on institutional racism. And then in 2014, we expanded that to deconstructing homophobia and transphobia workshops. Those were created, that one was created for us by the Center of Excellence for Transgender Health and the California STD HIV Prevention Training Center, both located in Oakland. And what has been so important about that training work is that it has given our staff, we have about 100 people, mostly domiciled in New Orleans, but also throughout the state. It's given our staff a common language with which to talk about institutionalized depression and a common analysis that we can pull concepts from as we do our work. And we have really let it impact how we make decisions and how we form or deepen relationships with communities and with other organizations. So I'll be talking about that more as we go along. We have also been shifting, and I want to say I should start by saying this. we are on a journey, right? You do not like go through a workshop and then magically become an anti-racist, anti-heterosexist health department. So we are on a journey. We have not arrived. I don't think anyone, frankly, ever arrives at that place, but it's about having a commitment to the journey. So another thing we're doing is changing our hiring and onboarding processes internally for staff. We have changed where we advertise for jobs and internships. You know, when I started in 2006, pretty much all of our interns came from Tulane. We love y'all. But we were like, you know, we have HBCUs in New Orleans. Why don't we have interns coming from Xavier and Dillard and SUNO? And so we do now. And so we're in the process of improving that. We have also changed some of our interview questions. There aren't like a concrete list of questions everybody has to use, but I sit in on interviews, and so I hear people ask questions like, why do you think people are poor? Or why do you think the rates of HIV are so high in Louisiana? And not that there's a perfect answer to either of those questions, but we are, you know, if someone were to say, oh, you know, because people are lazy or they don't want anything or that's all they know, that might not be someone who's good for our team, which we are intentionally shifting our organizational culture to include people who have some foundational interest or commitment to equity and to social justice. When people come on board, they go through a new staff orientation process that includes a presentation on disparities, on HIV disparities, and why those came to be, and inequities. And that's true whether you are going to work in the business department and process contracts, or you're going to be in the prevention unit out on the street doing frontline work. Just because we want everyone on our staff to have a common understanding. And that is equity work. I mean, it really is about shifting your culture. The third one here is annual report, which should be going around the room. So we've created an annual report for many, many years. Our surveillance department, that's who put that out, and it's fantastic. I'm sure some of you are looking at it right now. But a few years as a part of this Undoing Racism and anti-heterosexism work, we included a full chapter at the beginning. If anyone's holding a report, it starts on page 8. And it talks about disparities and some of the reasons why the disparities exist. So it talks about poverty, it talks about incarceration, it talks about things that, and then it's referenced throughout the whole report so that if you skip that chapter, you're going to be reminded of it later on. And the reason for that is that we know that it's, if you're going to put out, and right now I'm really talking to the current and future researchers in the room, right? If you're going to create and put out into the world statistics, it's so important to give context to that. Because if you don't, what may happen is that you inadvertently end up re-stigmatizing the communities that research or that those statistics are about. So we have a real commitment, and that's why I have a love-hate relationship with fact sheets, because they very rarely give the space and the time to paint a full picture. I know that we live in like a soundbite society, but it's just so important, especially when you're talking about communities, specific communities and the hardships they face, that we give some kind of context to it. We have shifted our language. Again, very much a product of going through the workshops that I began by talking about. So by show of hands, how many people here have heard of people first language? Okay, good, about a third to half of you. So really what that means is just honoring and respecting a whole person and realizing that they are more than whatever condition they may have or whatever activity they engage in. So, you know, instead of saying HIV infected, we say a person living with HIV. Instead of saying injection drug user, we say a person who injects drugs or a person who uses drugs. Because everybody is more than a decision that they make or a condition that they have. And then this is also, the concept is larger than just literally saying people first. It's also just, again, honoring how a person identifies themselves or the community with which they identify. So you don't have to say a person who is gay all the time. If a person identifies as gay, then it's cool to just, you know, to use that word that way. But that is the reason why when I showed you that tree map and it said MSM on there, that we at the health department have a problem with using that term, men who have sex with men, when we're talking about people or whole communities, because it is reducing a person down to a sex act. there is no such thing as an MSM community. There aren't MSM pride marches, and there aren't MSM gay bars, right? MSM bars. So that's a term that the CDC, it's a CDC risk category. That's all it is. But not choosing, when I talk about shifting our language, we've made a conscious choice to say gay, bisexual, and same gender loving men when we're talking about that community. And we do that during our CDC site visits, when we write our reports to CDC. We push back when we feel like they could be using different language. So these are all ways that we are, and I'm not saying, once again, I'm not saying that we do it perfectly all the time, but it's about making that attempt. And another benefit of the workshops is that we have deepened our relationships with each other. So we can loving and respectfully challenge each other too. Like if someone says, this, I read about this grant that's if you're working with IDUs, we'll be like, don't you mean people who inject drugs? Like trying to help each other out that way. So that happens too. Our funding commitment is that we are really doing what we can to put our funding where our mouth is. So we are committed to offering the Undoing Racism and the Deconstructing workshops indefinitely. We bake them into the grants that we write, whether that be to CDC or to HRSA. And we also support staff time. So during a work day, people can step out of their job description to participate in the Health Equity Action Team. Sometimes we have half-day meetings when we're really working hard, and our management team makes it okay for someone to step away if they're in the business unit from processing invoices for almost a half a day to go participate in this kind of work, because we see it as all of our shared responsibility at the STD HIV program. And so I'm going to move now into external relationships. Now, what I'm going to go over on this slide and the next one, I purposefully left off all of our core work. So yes, we use an equity lens when we do HIV STD testing, when we give out over 3 million free condoms every year, when we support the provision of PrEP and PEP, when we fund agencies to do case management services. All of that are like core functions that we have to do, and we apply health equity lens to that. But I specifically wanted to point out some things that I was hoping might be useful for you to take back to your organization. So one is community advisory boards. We have always had community advisory boards. They're generally, and so in our context, they're made up of people living with HIV and or folks of color and or LGBT identified people. But the way that we engage our community advisory boards has shifted through this equity work. So we understand that in order to foster more connection and respect and meaningfulness, that there has to be real decision-making power at the community advisory board. So I'll give you two examples of that. One is that we have a program called Health Models, and it incentivizes people living with HIV to achieve and maintain viral suppression. And so when we were building that program, we leaned on the community advisory board to help determine what the eligibility criteria be, what the actual incentives would be, how often they would be given out. And a lot of those decisions are still in use today.
I'm sorry, can you shift your
Sorry.
microphone? Thank you. Sorry to interrupt.
No. Is that better?
Thank you.
Yeah, sure. And so that's one way. And then another way is that more recently our HEAT team created a client satisfaction survey that we hope we're going to pilot it this fall at an organization in Shreveport, and then try to disseminate it statewide next year. But it's really targeting, or sorry, I don't like that word targeting, but it's really prioritizing people of color and gay and bisexual, same gender loving men and transgender individuals, and what experience they are having at some of the organizations that we fund for prevention and services. And when we spent months creating it, but then we took the extra time to send it around the state to different community advisory boards so that they could tell us whether or not those questions made sense. Did the language work? What were we leaving out? And we use that feedback to what is now the final product. But if you're gonna, what I've learned is that if you're gonna ask for feedback, you better use it, because these people don't want to be treated like tokenized or just like you're checking off a box or going down a list. So we really did take their feedback to heart. The next one is policy work. You can't not talk about policy when you're talking about attaining health equity or any other kind of equity. So what's difficult about policy work where I am is that state health department workers cannot directly lobby or advocate for or against any policy or legislation. We can't. However, what we can do is support community coalitions that are doing that direct advocacy work. So we can, if people need stats, they need information, they need science-based information, we can provide that. We can help in other logistical ways, and we do. Like there are staff that serve on Reproductive Health Coalition. There's another coalition around HIV decriminalization. We have influenced policy related to first and third trimester screening for pregnant women, for greater access to syringe support services programs, things like that. So just that policy work stays at the top of our head, and even if I guess what I'm saying to you all is even if policy isn't your interest, and believe me, I am not a policy expert, it's still important to work with people who are working on policy, is what I'm trying to say. Training and funding requirements. So we baked into our community-based organization contracts that they attend workshops like Undoing Racism and Deconstructing. So not always a popular addition. And after staff, community-based organization staff goes through it, it's up to them how they use it or not. But we just, in the spirit of equity, we want people to have access to an analysis around institutionalized oppression, right? And to make sure that that becomes a part, as much as possible, a part of our movement, not just of our work at the health department, but of our movement to end the HIV and STI epidemics in our state. And then we have increased focus on community-facing products. So our website, our social media, printed materials, we want to make sure that we're not re-stigmatizing the communities that we're trying to reach and that are most vulnerable to HIV. And what you see at the bottom there is a billboard we put out, you may have seen it last year, about PrEP, trying to raise awareness about PrEP across New Orleans. And we were very intentional and purposeful to not include any couples on it, no people on it, because we want to remove the stigma around PrEP. Excuse me. We want moms and grandmas and aunts and uncles and cousins to know what PrEP is, and if they themselves or if one of their family members ends up with a bottle of PrEP, that they support them. They know what it is and that they support them. Oh my goodness! Does everyone here know what PrEP is? Raise your hand if you don't know what PrEP is. Okay, pre-exposure prophylaxis, once-a-day pill to prevent HIV. Okay, I have to. Reducing barriers for community member access. So we don't want to we know that historically institutions like ours, health departments, can function as a barrier for a lot of people in terms of accessing prevention and care. And we want to do everything we can think of that's in our power to reduce those barriers. So these are things you can do too. Like we just took a hard look at our paperwork in terms of our HIV test forms, our applications for insurance, and be like, do we need all these questions? How are we using the answers to all of these questions? Can we shorten this and make it easier for people to fill out? Also, some of these questions are invasive. Is there a way that we can word this differently so it doesn't feel like people are giving so much of themselves when they're just trying to get into care or get insurance or get tested for HIV? So, and once again, not to say our forms are perfect, but we are trying to minimize those burdens. Another example is that we worked within other bureaus in the larger Louisiana Department of Health to get some of our staff read-only access to databases so they could verify HIV diagnosis and expedite insurance applications. So the whole idea is like connecting people as fast as we can, right? So those are just some of the ways, I'm gonna wind down here. Those are some of the ways that we are working toward equity in our program. And so I just wanted to leave you with a few closing questions and the thought, which is, what does your organization or agency or group need to better understand? What problem are you trying to solve? And I mean, I would say ask why, like answer and then ask why about 4 more times. And then you'll get to something close to what the actual problem is that you need to better understand. And then simultaneously, what's your vision for equity? Because we don't want to just talk about what we don't want. We want to talk about what we do want. What kind of city or state do you want to live in where your area of focus is concerned? And then last, there is no perfect anything. There's no perfect starting point. There's no perfect process. I think, a lot of us get caught up in perfectionism and trying to do things in this very particular way, and just realize there's going to be fits and starts, and that's okay. I had a seasoned activist tell me one time that if what you're doing around justice or equity feels messy, then you're probably doing something right. Because, I mean, the nature of trying to deepen or form relationships with communities, trying to maybe, get outside of your silo and work with an organization or a group you haven't before, it might get a little messy, and that's okay. So I just wanted to end on that note, and thank you all very much. What's this?
I guess I will. Thank you so much. My name is Anna from Salute, and if you guys have any questions, raise your hand. Yes.
Oh no, just Julie.
In 2017, the report saying that it's Black women, cisgender, second Black women who are the highest risk for HIV, which shocked me because the bulk of incident cases are amongst Black men who identify as lesbian or gay or bisexual or together. So what do you feel, talk about this point, what do you feel is really this? Attack the research first, like, or the bulk of the research is about men. That's the way the case is, but do you think it should be more research focused, or do you think it should be more outreach focused towards Black women, which will not be especially Black women?
Yeah, the latter for me. I mean, I feel like as many ways that you and whatever groups you're working with can reach out to other groups of Black women to find out, in regard to healthcare in general, not just HIV, right? But it's like, what might keep you or the people and your, other Black women from going to a clinic, or what are the barriers they face along the way? And then who else do we need to partner with to fully understand all the barriers, right? Like, there's so many. It's, it's community violence, it's transportation, it's mass incarceration, it's, so the possibilities in terms of partnering with folks to fully understand the problem are endless. But I think that's also true in terms of how to envision, solutions. But I think,
I'm sorry.
I also should just, I should also just be clear that I'm not a researcher, but I have a whole lot of respect for researchers and the importance of research. But I where I go first in terms of I just go to community first to gain knowledge, right? I think that they are the expert of their own experience. And so how to engage them to get the answers that you feel like you need to, and then to reach equity for Black women is really that's the question, right? But yeah, is that, okay.
So you were talking about PrEP. Some people felt in the community it was geared towards more people of color here in New Orleans, but you said the goal was to make sure it's accessible to everyone, or as a location of the billboard or even a Facebook ad. So to people maybe because of the history of racism and health homelessness that people may have taken the wrong way to just happen to be placed a billboard this side of town or at this clinic where majority of people of color go, or what are your thoughts on that?
Yeah, and I skipped a piece of the story too, which is that in terms of, so what you're talking about are like billboards out in the world, but we also did at the same time, we were rolling out social media around PrEP, and we were going onto sites like Jacked and Grindr, and so we were doing a lot of marketing that we were intending to reach gay, bisexual men of color, and we got the message from a cab and then just from general people being like, stop doing that, because you are doing what you don't want to do, which is further, stigmatize us. And so that's why the billboards and the example I showed looked so general. Now, in terms of the billboard placements, where in town it went, I can't speak to that well. The other thing is that, and I think this is actually a good thing, there were a bunch of different types of billboards all over. So I don't know if you're referring to ones that we placed out, but there are other FQHCs in the city that were doing their own advertising about PrEP. I know Crescent Hair had some, and St. Thomas Community Health Clinic had some, which again, I think is great. I think the more people can know about PrEP, the better. But so like to your question, I don't know firsthand exactly where our billboards were placed. I do know that the intention was to try to get as many people aware of PrEP as possible. I think there's also a conversation about where billboards are. Just in, you know what I mean? Like, because if you go like to the affluent neighborhoods uptown, there aren't billboards, right? So yeah, I'm sorry I don't have a pad answer, but yeah.
So with PrEP and you all learned the distribution of it, I apologize for missing the statistics on the effectiveness of it in our community for HIV and AIDS just overall.
Yeah, I think some of that is that information is still to come because it's still so new. And since 2015, 16, it's been really recent that we've been actively supporting organizations. We can't pay for the medication itself, for PrEP itself, but that we've been actively supporting agencies to, for example, hire PrEP navigators and really intentionally support the provision of PrEP. And so I don't have hard numbers for you about how that has impacted our HIV epidemic yet. I think that's still to come. Yeah. I think we have a long way to go, actually.
I had a comment and a question. My comment was about the PrEP issue, and I think one of the reasons why it's so complicated is because we know, I think it's 73% of PrEP users are white, gay, bisexual, same-gender, loving men. So then people are like, oh, we see that new infections are maybe among Black LGBT communities, so we want to, promote PrEP there. But I think the missing piece is at actually on a provider level, right? If you're going to a clinic and they're rushing you in and out, and there's 100 people in the waiting room, your doctor's not going to have that one-on-one care and be like, hey, I noticed that you have sex with men. Did you know about this once bit of called PrEP? Whereas a lot of white, middle class gay men have private doctors, have private insurance, and their doctor really has the time to talk to their patient and be like, have you ever heard of this? And that's something that we've heard a lot. Is no one's ever mentioned PrEP to them because they're main source of health cares in clinics, et cetera. But my question to you was about the MSM category. I'm interested in your thoughts on this. Because there's one reason why I didn't like it. It's because we work with adolescents. It's really hard recruiting adolescents. We're recruiting MSM adolescents, and a lot of them are hesitant to identify as gay or bisexual just yet, but are engaging in high-risk behavior. So it's hard for us because I'm curious as to what you would put on the questionnaire, because it's hard to ask a 17-year-old who's not ready to identify as gay. If we ask them, okay, have you ever engaged in sex with a man? They may say yes, but if we ask them, are you gay? They may say no, and they may not get into our program.
Yeah, no, that's a really important distinction, and I think there's nothing wrong with asking both questions, so that you can know by the answer that if they did indeed say that they had sex, they're a man who has sex with men, that they would be eligible for whatever program you're talking about. But then also, if they did identify as gay or same-gender loving, there is a space and a place for that. So I think both are important. And I think, I know it was a comment, not a question, but I like to talk about PrEP. I think, yes, I think if people are not getting proper time with clinicians to talk about PrEP, that's an issue. I think that we still don't have enough clinicians in general that actually know about PrEP. We take for granted that because we do, everybody does. But I meet doctors and nurses around the state all the time that are like, what are you talking about? And I'm like, what are you talking about? So I think we have a long way to go with education. I've been working in testing for a long time, and nobody's going to be offering PrEP if they don't first offer HIV testing. So I think, it's incumbent upon me and a lot of us at the health department to make sure that routine screening is happening in the first place. You have to know someone is negative before you can even really refer them to PrEP. So that's another piece of the puzzle too.
Thank you for this. You alluded to the messy, or spoke directly of the messiness of this work. I think you alluded to some of the challenges. So I just wanted to ask what your sort of self-care in terms of organizationally, like how the energy to keep working at something that's hard, or personally, either of those, or both.
I think part of it organizationally is that we have really strong supportive leadership. So I feel super lucky and I love my bubble where, because I can go like through 3 layers of leadership and all of them are 100% on board with this. So they support the work of the Health Equity Action Team. They carve out space and they're cool with us like stepping away from our desks to have those conversations. We try to, this is really heavy and super serious stuff, talking about racism and heterosexism and the disparities that come out of them. And so we try to educate ourselves as a group, but do other things like watch movies that are related to those topics, but that then we can have discussions afterward. Sometimes it's not always fun, but it does give us a way to vent and release, and I think that's self-care. One thing we did a few weeks ago is that a group of our HEAT members, I don't know if y'all saw, there was a installation at the New Orleans Museum of Art for several weeks. It had to do with the upstairs lounge fire, and then that was one artist. That was our sort of impetus for going. But then there were some other, some other pieces about other cultural groups and communities in the greater New Orleans area. And so we did that together, and we were, allowed to leave an hour early and go to the museum together. And I feel like that it's relationship building, but again, it's also self-care, and it helps us feel, for me, the more that I learn about disparities, the more validated I feel in focusing on this work. And that's what was so important for undoing racism to me, is because there's so much history that, I don't know about y'all, but I wasn't taught in terms of white supremacy and the ways that our country was built to benefit white people to the exclusion of people of color. And so just that, for me, that's self-care too, because it helps me feel like justified in what I'm doing.
I had a question.
Yes.
Do you, and when I say you, I mean like the health department in general, what efforts, or do you have efforts of kind of getting all this data, like the book that we were passing around, out back to the community?
Yeah, so like I said, the annual reports are available online. And so we do everything we can to make sure people know where they can go to get it. And again, that's louisianahealthhub.org and ldh.la.gov. And then we do create some fact sheets. So, there are days throughout the year, like Native American HIV Awareness Day, or, and so we create shorter fact sheets about,
like
in relation to that day. Yeah, and then try to, and then we disseminate those out to all of our community partners and hope that they will then also, continue forwarding it on.
Actually, do you know if other programs within OPH have anything like the HEAT, or is it unique to SHIP?
I'm happy to say it is not unique to SHIP. So the Bureau of Family Health has a HEAT team, and actually theirs was named HEAT First. And we intentionally copied their name because we are trying to start a movement within the health department where every bureau has its own equity focus, right? So I have a vision, I'm looking at sugar cakes, I have a vision for for like a LDH Keep conference. And so that would pull in like emergency preparedness and, you know, all of the different, I mean, LDH is huge, but that we can one day be having a joint conversation.
Know if there's currently any like syringe exchange programs or like what the legality of that is present in Louisiana?
Yeah, there are some syringe availability programs, and if anybody knows more, feel free to speak up. Yeah, go ahead.
Preston Care has one.
Yeah. And there was legislation passed this year that supported access at the state level, but it, at the last minute, there was something written in that said you have to get your city council or your local municipality approval first before you could roll out a syringe services program. So less than ideal, but you know, it paved the way at least, and hopefully there will be groups, advocacy groups that will improve upon that legislation in the future.
If you want to run syringe access program and also a tri-stereo, a lot of information about your availability and growth.
Bless you. All right. Thank you guys for staying till the end.